This is kind of another big area of referral that we're often asked to help with. Irritability and aggression. As with ADHD and anxiety, these are really common. We see this pattern of disruptive behavior in anywhere from a quarter to half of kids who come with ASD. And I like to just sort of define what we mean by irritability and what has been looked at in clinical trials. And for my purposes, when I'm seeing children, I kind of try to separate into a couple of different categories. So one is mood lability or mood reactivity and outbursts, and that might be things like extreme tantrums, moods changing at the drop of a hat, highly reactive, kicking on the ground, screaming, running away, versus aggression, which is more of a targeted behavior that can be verbal or physical, that can be directed at others or at the self or at property. And that for me is also, depending on whether it's one, the other, or both, potentially influencing what kind of treatment I might recommend. We did some of these diagrams before with anxiety, but a lot of these things are going to start to sound familiar. So there's a lot of symptoms of autism and cognitive deficits that kind of travel together with autism that set kids up to have these kind of symptoms. So some of these are familiar and they overlap with anxiety, things like sensory differences, being physically uncomfortable. Sometimes these behaviors are just repetitive patterns of behavior that may not serve another purpose. So kids who, bump their chin against their hand or against their teeth might actually do damage to their skin, but it's not a targeted behavior. It's sort of a repetitive self-soothing behavior. We see these kinds of behaviors more commonly in kids who do have some communication impairment, which I think makes sense. If you're unable to tell people verbally what's bothering you, you might show them physically. Sometimes these become reinforced patterns of behavior where it's serving a function, and we'll talk a little bit about what those common functions for these behaviors are. Mood reactivity, again, I use this to illustrate a couple of points, particularly when I'm working with families and there's some question about why their child has these challenges, and a lot of times there might be some misconception that this is a mood disorder or this is bipolar disorder. And so partly I think it's our responsibility to educate about why these behaviors might be presenting in their child. And it's, again, often related to some of these challenges with executive functioning, challenges with flexible thinking, anxiety, impulsivity, all of these things that are coming together and resulting in a behavior which looks an awful lot like a mood disorder but isn't. Okay. Here's what we recommended in 2017. We have our comprehensive assessment. Our level 1 was non-medication based treatments and treating comorbidities. Level 2, we decided at that point to think about using things like guanfacine as a first line for mild to moderate irritability. Our level 3 is antipsychotic monotherapy, specifically risperidone and Abilify. And our level 4 is reassess and consultation. So we'll keep that in mind going forward. So for our assessment, it's probably starting to sound repetitive. Always we think about medical explanations first. Some of medical problems are overrepresented in our population here, so we're thinking, could this be a seizure? Could there be wisdom teeth coming in or an abscess? Is there a GI explanation, something like constipation or reflux? Might they have an ear infection? And so our first line of assessment is always to rule that out and make sure we're not missing something very treatable. I think a lot about other medications, particularly if I'm seeing a child for the first time that's already prescribed a lot. I'm thinking about things in particular like stimulants, SSRIs, or anticonvulsants that might have behavioral side effects. I'm always thinking medical first too, especially in kids with lower levels of verbal communication who have a sudden onset in a behavior change. So it seems to come out of nowhere. Like we do for all our patients, we're assessing for environmental contributors. And some of these are a little bit unique to autism. So, certainly they're going to respond to all the traditional stressors, things like, chaotic households or separations from their parents or, domestic violence. But then also there are some more routine things that kids with autism are going to react to more than the average child. That could be changes to their routine, changes in caregivers, even as if it's a substitute teacher at school or a new aide or a new nanny, major life transitions, and of course trauma. We're here again wondering, could the behavior be better explained by another primary psychiatric diagnosis? That could be something like depression or anxiety. And again, especially with this heightened fight or flight response, I think anxiety can often be a big driver of aggressive behavior in these kids. And then less commonly, things like psychosis. So the other thing that we should be doing when we're first assessing this kind of behavior is trying to think about, is there a function that this behavior serves that is maintaining this behavior? And this is the basis of a functional behavior assessment, an FBA. I'm not talking about doing a formal FBA from your office, but to really do a less formal inventory of the kinds of things that might be maintaining that behavior, or asking an ABA agency or even a school to do a formal FBA. And as before, thinking about safety concerns. Okay. So here are some of the most common reasons that we might see behaviors like aggression and self-injury. And I don't mean to imply that these are manipulative or intentional behaviors, but rather they're behaviors that are being maintained through reinforcement in some way. All right, and so one is escape and avoidance. So we see that fairly commonly. Kids learn fairly quickly if they behave in a certain way that demands on them, may back off, all right, and they learn that that's an effective strategy for reducing demands that are uncomfortable to them. It may give them access to things that they want or that they need. So kids who really need to move and have a movement break might act out in the middle of class, and then the consequence might be they get to take a walk around the building with their aide. So that becomes their way of asking for a break. This can be a way of communicating discomfort or frustration for kids who don't have other means to communicate what they need to. Sometimes it's attention driven. So, we know that kids often don't differentiate between positive and negative attention. So sometimes these are ways of getting attention from others, or even trying to connect with others in ways when they don't have more adaptive coping strategies. And then I think the hardest thing to treat is aggression that is internally driven and sustained through what I call automatic reinforcement. So these are things like compulsive rituals, repetitive behaviors, and self-injury that is done to serve some internal purpose or meet a sensory need. And so it's not necessarily driven by external factors, it's sort of internally driven. Okay. So our first level of recommendation from last year was not a medication treatment. We had decided on behavior therapy as a first line approach, particularly when the irritability is mild to moderate. And ABA is kind of our gold standard, with the caveat that sometimes that's hard to get. As I know we've talked about, it's not available in every area. There's long waiting lists, there's issues with insurance approval. But this is what we should be aiming for. There's some other behavior strategies with some evidence, PCIT, CBT. We want to treat anything that's medical and recognizable first, all right? And going back to our de-prescribing talk, eliminating medications that might be causing more harm than benefit. We want to optimize the supportive therapies. I think particularly I'm coming around more and more to communication. So wanting to enhance the strategies for communication as much as possible, and that might be through assistive or adaptive technology, that might be through visual supports, sign language, lots of different ways to try to help kids communicate to us what they need. OT can help with sensory deficits, social skills therapy can help with peer interactions. And then psychoeducation and behavior guidance. So part of our job is as coach to the parents about how to structure their home lives, how to use schedules, how to create a space within the home for kids to go to when they need to cool down so that they can learn to self-soothe and self-regulate, using things like break cards at school so kids can really easily ask for a break without having to act out first to get their break, and then positively reinforcing efforts to cope with strong feelings, even if their result isn't always 100%. We want to praise the effort. Okay. So moving on and thinking about medication. So at this point, there still are only 2 medicines that have FDA indication to treat irritability in kids with autism. That's risperidone and that's aripiprazole. Those are older studies. The risperidone was based on 2 large randomized controlled trials, same thing with Abilify. And so I think not a lot of new research has come out in this country. I did find 1 new randomized controlled trial in a sample in Japan, and it looked like the impetus for that study was trying to get approval for a medication other than risperidone in their country. So they looked at 95 kids, 6 to 17. They were randomized 1-to-1 to aripiprazole or to placebo for 8 weeks. 8 milligrams was sort of the mean dose for that sample. It was flexibly dosed. They did find aripiprazole superior to placebo for irritability on the ABC subscale and on a global impression scale. And they started to observe those effects around week 3, and they were sustained and built through week 8. They did not find a significant difference in treatment response, which they defined as a combination of much or very much improved on the CGI, plus at least a 25% reduction in the ABC irritability score. And I think I would just highlight there that there was a fairly large placebo response, which is pretty typical of clinical trials in ASD. They reported some mild drowsiness, but no serious adverse events. They did see a significant increase in BMI and cholesterol, which is not necessarily new news for us. So what new information does this add? My takeaway was that their findings really mirror the findings from randomized controlled trials that have been done in the United States, where we see separation from placebo, but also a large placebo response. It was short-term follow-up, so we can't really project beyond that 8-week mark, and that there are metabolic factors that still remain a significant concern for us. So I didn't spend a lot of time for this part of the talk going back over the randomized controlled trials for these atypicals, because I think they're pretty well established at this point and they speak for themselves. But what I have seen more of is more attention to some of the metabolic adverse events as we use more and more of these medications. I think we're becoming more cognizant of these side effects. So what I found was up to a quarter of kids with autism will be prescribed a second-generation antipsychotic. It's a pretty large number. And because we're talking about neurodevelopmental disorders, these are kids who may stay on these medications potentially for years or even into adulthood. So we're talking about a lot of lifespan being treated with these medicines. So there's some chronicity there. There was a randomized trial in 2018. This was not specific to autism, but this was children who were prescribed an atypical for any indication. I think the most common thing was disruptive behavior disorders like ADHD. And they were randomized to either get risperidone, aripiprazole, and olanzapine. And they all had aggression for some other diagnostic reason. And they treated them for 12 weeks, and their primary outcomes were metabolic outcomes. And what they found is just in 3 months, they saw significantly higher rates of abdominal obesity, total body fat, and decreased insulin sensitivity. And this isn't necessarily new information either, but olanzapine more so than risperidone and aripiprazole, all of them separated out as significant increases. And that's in 12 weeks, right? So that's a kind of a short period where we're seeing pretty significant metabolic changes. I was struck by this other study that I saw recently too, which was looking at a large number of Medicaid-enrolled children in Tennessee, 250,000, who were prescribed high-dose second-generation antipsychotics. And what they found was that there was a 3.5-fold greater risk of unexpected death, 4.3 higher risk of death due to cardiovascular or metabolic causes. And they were comparing it to children prescribed lower doses of those same medications or to what they call control meds. And that was other psychiatric meds like SSRIs, stimulants, and mood stabilizers. I was struck by this because that difference was not accounted for by higher rates of overdose on their medication, suicides, or accidents. And they defined high dose as a chlorpromazine equivalent of 50 milligrams or higher. So I don't know, I don't use a lot of chlorpromazine, so I needed to kind of, it's not a large dose, and you can see here, I just highlighted risperidone. This is gonna be really hard to see. All right, so this is equivalent to 100 milligrams of chlorpromazine. So half of 7.5 milligrams of Abilify. So 3.75 milligrams is the equivalent, and 1 milligram of risperidone. So these are really, so mostly what we're prescribing is, is approaching high dose, what they would define as high dose second generation antipsychotics. So it doesn't take much to get to that threshold. So we'll talk about some strategies for how to deal with this, but there have been some studies looking at Metformin, which of course is a medication for type 2 diabetes that increases insulin sensitivity and decreases intestinal glucose absorption. There have been some interest in this as a possible adjunct treatment to manage some of these metabolic effects that we see with second generation antipsychotics. And the data in kids without ASD is pretty mixed. I found one positive and one negative RCT. There has been a study looking specifically at metformin in children with ASD who are taking an antipsychotic. Not a large number, but 61. This was a 16-week RCT followed by a 16-week open label. And the younger kids were getting 500 milligrams twice a day. Older kids and adolescents, 850 twice a day. And they did find a difference in BMI Z-scores, but not a huge difference. So a minus 0.1 difference in their Z-score. They did find a more significant decrease in hemoglobin A1C of about 1 millimole. So that's a little bit more significant. And then they didn't find changes in other metabolic variables like things like lipid panels. So what they found was that BMI did decrease in that first 16 weeks, and then in that open label phase for the kids who were taking it now for 32 weeks, was that they maintained that decreased BMI, but they didn't see any further decrease beyond that 16-week mark at the beginning. Okay. So here are some other strategies to consider. There are some antipsychotics that have a lower propensity to cause weight gain than others. Risperidone is one, okay, Geodon. So there is, and these are all studies within ASD. There's one supportive open label study in case series. There haven't been any randomized controlled trials. The need for EKG monitoring is something that we consider. There has been one large and negative study of lorazepam in autism. And then this is not necessarily to add to guidelines, but something that I found interesting is there's a group out of Ohio State that has published a few papers on using loxapine, which is a first-generation antipsychotic that can behave like a second-generation antipsychotic at very low doses. So it's inhibiting D2 receptors and 5-HT2A receptors, similar to what aripiprazole does. It has less risk of weight gain when it's used in lower doses. And this group found that it was helpful for irritability in a 12-week open label study, and that they were able to transition kids who had been on second generation antipsychotics onto loxapine, get them off of the SGA, and found that their metabolic factors improved. So something to consider, right? So we've sort of shifted towards using predominantly atypical antipsychotics, but again, we're kind of have to be aware of the risks in doing so to health at the same time. So here are some suggestions that I came up with for how to manage the risk. One is that we can consider alternative medications first, particularly when the level of irritability and aggression falls in what we might consider a mild to moderate, where there are not major safety concerns. We should always be giving lifestyle counseling on diet and exercise, using our minimum effective dose. I think we agree that's just good practice. Consider a switch to one with a lower metabolic risk. And I know I certainly have patients where some of these medications have been pretty life-changing, and if the risk of taking them off is pretty great, and they've had significant metabolic effects, is to consider adding metformin. All right, so I didn't include a review of that literature from last time, but we can definitely talk about it if that would be helpful. So this is debatable. I had a hard time figuring out what sort of grade of recommendation to give these medications. We do have good evidence that risperidone and aripiprazole have response rates in the 50 to 75% range for this symptom cluster in autism, and it's pretty consistent across open label studies and RCTs. However, I docked it a little bit because of the metabolic risks, so I landed at a B. And I think this lines up with where we've recommended it as a level 3 intervention in our guidelines, but we could talk about that. Lorazepam, we talked about last time. The one large RCT had about 150 kids, did not support its use. So I said I guess level of evidence would be better than grade, but this would be against its use. I didn't suggest that we include it in the guidelines. All the other atypicals have been studied in either small open label studies, case series, or chart reviews. And data is mixed on a lot of those. There's some modest evidence for ziprasidone, negative evidence for quetiapine, modest evidence for olanzapine, but huge amounts of weight gain in short periods of time. The paliperidone studies are small, and they're very similar in terms of response rates to risperidone. We have that one open label study of loxapine, and then we have I included metformin just as a side to consider offsetting some of the harm if these are medications that the child truly is benefiting from. So to summarize, we want to always focus first on behavioral functions and behavioral therapy, and that can be very effective when it's done well. I said consider an alpha-2 agonist for the kind of tantrum outburst and low-level aggression that might come with impulsivity and doesn't present any major safety risks. There's no real evidence to back that up. That's just kind of a personal practice point. Risperidone and aripiprazole are still our best options for severe aggression or self-injury. We may want to consider, and this may be getting into the range of specialty care again, but if we're thinking about subspecialty care, thinking about things like ziprasidone or loxapine as third-line options, and being really vigilant with our metabolic monitoring. I put it, something I've started doing, and I don't know that there's a lot of evidence for this, but some of my mentors have done, is to add a total insulin if there's either a family history of type 2 diabetes, or if they've had rapid weight gain, or I've seen a trend up in their hemoglobin A1C, even if it's not crossing that threshold into prediabetes or diabetes. Sometimes we'll see a rise in insulin, which is indicating some resistance even before we get to that threshold. And I'm more conservative in those kids in trying to reduce dose, get them onto other things, get them off of things if we can, even before they reach that point where it's a problem. And then, I put in here a little caveat that counseling about weight management is great, but these are kids that are very challenging to get to change their diets. So lots of them have very limited carbohydrate heavy diets. They'll eat 6 foods. So you can ask a parent to give them whole grains and vegetables and fruits for every meal, but some of those kids are going to starve if that's all you present them with. So we have to be mindful that that is good advice that we should be giving, but for not every kid will they be able to be successful with that kind of advice.